Hello everyone, and welcome to the cholesterol lecture. We talked about lipids during the cardiology module briefly, and I'm going to go into a little more depth on lipid management and talk about one newer class of drug, I should say, and go into some more detail on how we manage lipids in different patients. So it's definitely a cardiology heavy application. It kind of slots into endocrine. Lipid management floats around a lot of different areas. There's a lot of recommendations, different disease state guidelines to manage lipids. So from diabetes to stroke prevention and cardiology, of course. So it does cover a number of things. So anyway, that's what we're talking about this week. Lipid management is all about preventing the poor implications of atherosclerosis, which is a disease where you get plaque buildup in the arteries. I'm sure we probably all understand a little bit about the pathophysiology of this process, but essentially what happens is you get too much cholesterol built up in the arterial wall, and eventually what happens is that plaque ruptures, and you end up with inflammation and possible occlusion of the artery. So you can see that as the plaque builds up, it prevents as much blood from flowing through. And your heart can actually sustain a fair amount of this before you get to a point where you might be getting angina or maybe even an MI or something like that. But the point is that eventually the arterial wall in this space just gets too stretched out and that plaque will break through. Then you can get a clot, and that's what causes a complete infarction. This is atherosclerosis is the leading cause of death in Western countries for the most part. And all patients who have this disease will be treated as if they have high cholesterol. So that's the whole mechanism behind why we're treating high cholesterol, is we want to prevent these plaques from building up and from rupturing. So cholesterol, there's a number of different options for cholesterol. You have couple different types of cholesterol we talk about. We talk about low density lipoprotein and high density lipoprotein, LDL, HDL. LDL is considered our bad cholesterol. Basically, it takes cholesterol from the liver and brings it to the cells. High density cholesterol, or high density lipoprotein, or HDL, I should say, is our good cholesterol that scavenges and center does the opposite of low density. And so when you're looking at somebody's numbers, LDLs should be low, HDL should be higher. That's generally what we think of as good. But there's a lot of shades of gray in there, and we'll talk about some of the guidelines and recommendations. Depending on what type of disease you have or what type of history you have as well, might change your recommendation for your guideline. And then there's triglycerides. Triglycerides are fat made by the body. Usually if somebody has high HDL or high blood glucose, they're going to have a high triglyceride level as well. They kind of go hand in hand. We don't generally treat high triglycerides, but sometimes we do, depending on what type of lipid panel the person has. Sometimes if the triglycerides are really high, it makes it difficult to calculate out the LDL correctly, so you have to treat them in order to be effective. And you can get much more in depth on how cholesterol is managed in the body from a pathophysiology perspective. If you want to dive into some of the more nitty-gritty details of how the body makes and processes cholesterol, I've got some more information here. I'm not going to go through it. This gets into more of the pathophysiology, so hopefully you cover that a little bit in your other class. But if you're looking for more of a scientific explanation of cholesterol, here you go. There's a little bit more information for you here. And again, this is just a diagram for the visual learners out there, and how you like to picture cholesterol moving in and out of the liver. And again, the whole treatment goal with cholesterol is to lower your LDL levels. And HDL, if we can get that up, great, but that's a little bit difficult to do with drugs. All right, let's get into the therapeutic side of things. So LDL goals, I put a question mark here because goals kind of change, and it depends on really where you're at with your risk factors and what type of prevention we're looking at. So with cholesterol, primary versus secondary prevention differentiation is really important. And just a reminder, primary prevention is to prevent an event from happening. Secondary prevention is to prevent an event from happening again. So secondary prevention would be like if somebody had an MI, then you start them on a statin. Primary prevention would be like, oh, this person's at really high risk for an MI. Let's get them on a statin so they don't have one. When it comes to primary prevention, LDL goals aren't necessarily as specific. So if you have really high LDL, like if your LDL is above 190 or something like that, then yes, certainly you want to treat them. But everything else is kind of a shade of gray with primary prevention. And you basically just want to start somebody on a moderate statin and call it a day. You don't necessarily monitor their cholesterol or target specific goals unless they're really high risk, which we'll talk about some of that risk stratification here in a second. So it gets a little confusing, I think, from a goal perspective. And the guidelines have gone back and forth about what goals to target and what goals not to. This is funny because these are old guidelines. These are from ATP3 that used to stratify risk, and then they would give you a specific goal of LDL based on your risk. And one of the interesting things was there's this optional, really tightly controlled LDL goal of under 70. And then another set of guidelines came out after this. ATP3s, I can't remember when they came out. They're in like the early 2000s. And then another set of guidelines came out and said, no, you shouldn't do under 70. There's no evidence to support that. Now, actually, the body of evidence is swinging to the point where we say there really might not be a lower cap for LDL. If you want to get somebody's LDL in the 20s, it actually does seem to have more benefit. So everything changes in medicine, and when it comes to anything cardiovascular related, and especially related to cholesterol management, there's a lot of studies out there and ongoing for these types of things because they do seem to be very impactful for people's health. So in this case, the under 70 goal is actually alive and well now, even though it was kind of taken out. So I left the ATP3 guidelines up here because they are kind of accurate for how we target it. But this upper stratification isn't necessarily as significant anymore. Basically, if you have risk factors, they're going to probably try to manage people pretty aggressively for the most part. Getting under 100 is usually kind of your starting goal. And then if you can bring somebody down further from that, that's just all icing on the cake. All right, so I said that there's a body of evidence shifting towards supporting LDL goals, but it's actually kind of limited if you look at direct trial. I found one trial that was a head-to-head against looking at, I think, stroke prevention and other cardiovascular risk was the main outcomes they're looking at, and they looked at look at two groups of people, one under 100, one under 70, and under 70 did actually seem to do better overall. So there is some evidence out there, but what's more important than that maybe is the expert consensus that's sort of coalescing on this push the LDL as low as you can idea. And that has to do with some of the new therapies that come out that are showing benefits in patients who are getting very, very low LDL levels. And I heard a presentation where they said there's really no J curve when it comes to LDL. So a J curve is like, you kind of have a diminishing return eventually, if not maybe a harm that comes if you don't keep your LDL within a certain range. And then if you end up going lower than that, you might actually get adverse effects and things like that. But they actually don't see that with LDL. It seems like for some reason you can just take away somebody's LDL basically entirely. It doesn't really have any adverse impact on them. In fact, it seems to prevent future adverse events in the cardiovascular realm, strokes and heart attacks and things of that nature. So it's kind of counterintuitive. You'd think our bodies would need some LDL for something, and maybe we do. I don't think anyone's out there with zero LDL, but maybe we just don't need that much. So it's interesting to see where this is going, and I think you're going to see a continued push for lower LDL levels in the cardiovascular realm over time. Okay, so the basic guidelines are looking at, talking about who should take LDL lowering therapy, and in this case, statin drugs are always going to be your primary drug that you're going to use in patients, and you're not going to use anything else unless you have a good reason to. So anyone with cardiovascular disease, angina, previous heart attack, stroke, or related condition will be on a statin. Anyone with LDL over 190, doesn't matter what else you have, you're going to be on a statin. Anyone with diabetes, aged 40 to 75. And for people with cardiovascular risk, having a 7.5% chance of having a heart attack or stroke or developing disease in the next 10 years. And that's a calculator I can show you here in a second. You probably looked at this in other classes, but it's a kind of a standard calculator they use in the cardiovascular world to predict disease. And then that in turn will tell you how to manage the person. And that tends to be how we decide on prescribing anti-lipid therapy. Lipid lowering via statins does reduce the relative cardiovascular risk about 20 to 30%. The higher the risk of the patient, the more the benefit. And again, it seems like the lower you push that LDL, the more benefit you get from that. If you want to go to the CV risk calculator, I've included a link for it here. You can get I think AHA has like an app you can get on your phone for it too. There's probably a number of different healthcare related apps that have a calculator like this. But the point is you plug in a bunch of variables. It has to do with blood pressure, cholesterol, whether the person smokes or not, age, things like that. And then it gives you a prediction of what type of chance they're going to have is developing an event or disease in the next 10 years. And essentially, if you meet a certain criteria, it's recommended you should be on statin therapy. There is some controversy around this. So some patients will argue, well, you could have a relatively healthy patient that has really nothing going on, but maybe they're older. And as you age, your risk factor for having a stroke or something goes up substantially. So you might not necessarily have anything wrong with you from a blood pressure or cholesterol, or maybe you've never smoked, you don't really have anything, but just your age alone will calculate to a high risk factor. And that is a bit of a controversy because people might argue, well, why should I give this person a statin when really they're very healthy for their age? But again, that's going to be an individual type decision. You don't have to prescribe statins just because the guidelines say so. It's just the recommendation from the expert panel. So certainly if you have a patient who's really healthy and they're resistant to it, does it matter? I don't know. That's going to be a conversation you have with that person. I think the evidence would say yes, it does. It does prevent complications, but there could be side effects with the statin too to think about. So risk benefit. The benefit probably outweighs the risk of the statin, but there's also things to think about with patient comfort level and stuff like that. Lifestyle modifications should always be considered a part of cholesterol management, stroke prevention, heart attack management, all that type of stuff. We should always recommend that our patients strive for weight loss if they're overweight and to get regular activity or exercise. Diet modification is going to be, there's a lot of different recommendations you could have with that. I would highly recommend referring somebody to a dietitian, especially if they have blood pressure issues and are consuming a lot of sodium or just have a high fat or off balance diet. Linking them up with somebody who can talk to them in plain language about how to read labels and how to adjust their diet so they can live a little bit healthier can be very helpful. Weight reduction via diet alone can lower LDL. You have to get a pretty substantial amount of body weight reduced to get to the point where you're seeing a good LDL lowering. And then there's the debate over whether these patients should still be on a statin anyway, which is probably the case. But you get a synergistic effect. So if you're taking a statin and you also have a weight loss plan to lower your LDL, that gives you a double benefit there. Long-term compliance with weight reduction programs can be challenging, and that's been shown in different studies across the board. There was an example of this study I put in here where there's almost 13,000 high-risk men. The reductions in LDL from lifestyle modifications didn't reduce significantly CHD or all-cause mortality. However, the LDL reductions were pretty modest overall. So there's a couple take-home points from some of the literature out there when it comes to looking at weight reduction or just lifestyle modification in general and cholesterol. You have to consider that, one, you have to lose a substantial amount of weight to actually get LDL reduction to the point where it's clinically significant. That's very difficult to do on its own. And two, you have to sustain that. So what this evidence usually says is, yes, you can get some LDL reduction, but it might be difficult to get a sustained effect and also any type of clinically significant benefit from that. And that's where, again, I am a supporter of the synergistic method of promoting lifestyle modification plus pharmacology. Okay, so let's talk about the statins themselves. I know, again, we talked about these very, very briefly, but what statins are HMG-CoA reductase inhibitors. HMG-CoA reductase is an enzyme that is a part of the cholesterol production pathway, and if you inhibit its use, or inhibit its function, I should say, it inhibits the process of the production of cholesterol to a substantial degree. Statins, since they've been out, have been the cornerstone of high cholesterol treatment. I would argue that there's probably no class of drug out there that's been more extensively studied than statins, and they still are studying statins regularly. They're useful for both our primary and secondary prevention, and ultimately we know exactly what they do, but the mechanism is not well understood. And the reason why is because there seems to be an inherent benefit you get from taking a statin regardless of the LDL reduction you have. In fact, there's lots of recommendations out there for patients who are statin intolerant or have a problem tolerating higher doses or maybe optimal doses of statins, just to be on whatever dose you can tolerate, and that's it. But again, the pendulum's kind of swinging back towards, well, we used to just say, yep, just get them a statin and that's really all that matters. The LDL isn't quite as important. Now it's sort of swinging back to say, well, actually, let's try and get that LDL down, even if they can't tolerate the statin, use some other drugs to do that. So we're seeing that time and time again. It's kind of interesting to see how those things change, and that's like over a 10, 15 year period. It's not a super long period of time, but as we understand more and more about how the impact of these drugs and their LDL lowering potential can be, we can understand more about how they actually might benefit patients. So anyway, we don't really know exactly what statins are doing. There's a lot of thoughts that, yes, they decrease cholesterol, but there might be more to it than that. They might help stabilize a plaque and prevent existing plaques from rupturing, and do some other things as well. Here's just a picture of the statins and how they work in the cholesterol synthesis pathway, if you're wondering. Statins, as you can guess by this lecture, are very efficacious. They're the most potent. Actually, that's maybe not the most true statement anymore. That's probably debatable. I'm going to leave that in there for now. But they are very potent LDL lowering drugs, and at least from an initial therapy perspective, they're highly effective at getting LDL down to a manageable level. Side effects are kind of all over the board, from very well tolerated to some patients get pretty significant side effects with them. This is a class of drug that, as you might imagine, is taken by millions of people across the world, and so we do see a very wide variety of side effects in different patient populations. You do get diminishing returns with statins, meaning the higher the dose you give, the less LDL reduction you get. So if you double the dose, you don't always get double the response, right? Most people will get their most significant bump, or decrease, I should say, in LDL based on their first dose of the statin they take, that whatever you start them at, their moderate dose. And then as you push them into higher doses, they'll get some additional lowering, but it's not going to be as substantial as what you saw initially. Statins don't really do much to HDL. You might see a modest HDL increase. But your highest potency statins, or again, the best ones at lowering LDL, are going to be rosuvastatin and atorvastatin. These two are both generic now and are relatively inexpensive, so we see them as probably the two primary ones used. I don't see, simvastatin used to be really common when it was generic, but I think now that these two are, every person who is on simvastatin has basically switched over. There's a lot of good data that supports rosuvastatin and atorvastatin being just more potent and able to get better LDL results overall. There's a lot of studies out there on statins. These are just a few that I pulled together and put in here. You can see that there's a number of different statins that they looked at. Actually, these don't look at any of the big ones, atorvastatin or rosuvastatin. But you can see that the reduction in coronary events, it's basically a slam dunk across the board. Every study looking at statins has shown a good benefit in as far as and all-cause mortality, stroke reduction, cardiovascular event reduction. And there's a couple other trials out there. I'll point out a couple big ones, but there's others that I'm not covering. But Jupiter trial was a big one in 2008 that looked at people with a high C-reactive protein. So that means that C-reactive protein was used as a surrogate marker for general inflammation. It looked at putting people on rosuvastatin versus placebo. This one actually didn't look at LDL. I think it did look at LDL, but it wasn't the primary target for it. So it wasn't like we're trying to target a specific LDL. They just said, all right, let's look at these people with high C-reactive protein, so again, high inflammation, give them a statin versus not. And the people who took statin showed significantly
reduced cardiovascular events and all-cause mortality compared with the other people. Again, that wasn't anything to do with their LDL. Certainly their LDL would have lowered on rosuvastatin. So again, the mechanism is tied in there. But the point in this study, and the interesting part of this study, was they didn't look at targeting a specific LDL level. They just said, let's give them rosuvastatin or not and see how they do. And that was a big study that expanded the primary prevention indications. And again, if you go back to the beginning when I was talking about primary prevention, we don't tend to get as nitpicky over the numbers of LDL as we do with secondary prevention or higher risk patients, where we really do try to knock down their LDL as far as possible. So when it comes to this, if you do give somebody just a moderate dose of a statin for primary prevention, they will likely have a pretty solid impact on their risk as far as decreasing cardiovascular event, the future of having a cardiovascular event. Prove It was a study that looked at high dose atorvastatin post-acute coronary syndrome compared with standard pravastatin and saw 16% reduction in death or major cardiovascular events. And that was one of the big trials that came out that solidified the current practice of prescribing high dose, high potency statins to people post-acute coronary syndrome. This table is on here to compare all the existing statins in case you're curious. I don't really have much to say about this. It's a lot of information. What I will tell you is, again, we pretty much use two statins, atorvastatin and rosuvastatin. Occasionally we throw in pravastatin. Pravastatin is probably the least prone to drug-drug interactions. So you can see there's no cytochrome P450 interactions. If you have somebody where drug interactions are really important, or you're really worried about it, like maybe a transplant patient, even in that case, though, you probably work around it. I'm trying to think of a good example. Maybe an epileptic patient, something like that, where the levels of their drugs are really important. You don't want to mess with them. That's where pravastatin might come into play. Otherwise, you have varying degrees of kinetics and things like that. But for the most part, we don't really care that much as far as different statins go. It's just more like, how great of an LDL effect can we get? Let's give that one and see what happens. There is a theory out there. You can see some of these are lipophilic and some are hydrophilic. And that the hydrophilic statins, like rosuvastatin, don't get into the central nervous system as much. And there is some association or thought that statins might cause dementia. So that might be one of the reasons why rosuvastatin might be better if you're worried about early onset dementia or something like that. But that's kind of a stretch. So anyway, I'm getting into the weeds on this, but we'll keep moving because I don't think, again, most of the stuff isn't really important. It's just how you compare the different ones and how you might look at where to start prescribing. And really, it's going to be that top row, the LDL reduction. That's your primary decision-making point when you're thinking about different statins to use. The brand names, just in case you're here, they're all here. Again, I think actually, pitavastatin I think is still brand name. I know I said it was brand name on the other slide. I have to double check on that. It's been around a while, but no one uses pitavastatin, so not a big deal. You have, this is just a chart to show your LDL reductions with the different statin drugs. So you see rosuvastatin up here. Again, if you're going to prescribe a statin, you're in almost every patient, you're always going to consider rosuvastatin as your drug of choice. A lot of medications we talk about in this course and classes we talk about, there's a lot of leeway for where you can start with different within the class. And within statins, there's really one preferred option. That's going to be rosuvastatin. And so you always should be thinking of that one as your first choice. The only reason you wouldn't use it is if the person had an adverse reaction to it, maybe they didn't tolerate it very well, then you could pivot to atorvastatin. But rosuvastatin, even at really low doses, gives you almost the same benefit as a mid to high dose atorvastatin. And it certainly gives you more benefit than almost any other dose of any other statin out there. So you can get a really solid response with just rosuvastatin, which is a nice reason why it's a commonly chosen statin first line. Okay, so rosuvastatin is the one we like the most. Atorvastatin's our second line. That's sort of the take home from that slide. Now, safety-wise, statins, again, are probably the most prescribed drugs in the world. Overall, they're very safe. Originally, when they came out, there was this thought that they caused hepatic dysfunction. This is super rare, and in fact, it's so rare that we don't even really think about it as higher than the general population anymore. So it's not really something that's considered. Usually, if it happens, it's going to be in the first 3 months of therapy. And the only time usually, if you start somebody on a statin, you're going to run a liver panel on them, if they don't have a baseline already. If they already have a baseline from a few years ago, that's probably fine. But I'd get a baseline liver panel. After that, the only reason you'd ever recheck is if you clinically indicate it, and then you'd look at ALT elevation and see if that's continued to be elevated on 2 more occasions. Then you could try decreasing the dose or changing to a different statin. Statins are category X in pregnancy, so we don't use them in pregnant patients. That's one kind of area where they can't be used. Memory loss was something that came up. It wasn't proven, but possible with certain statins. So again, I talked about the hydrophilic lipophilic hypothesis there. The thought is if you're concerned about that, or if you have a patient who's concerned about it, rosuvastatin is probably the better choice because of that. Diabetes, there is a slight association with diabetes and statin use. I think it's like under 1% of patients end up with a kind of a new onset of diabetes. It's pretty rare overall, but it is something to consider, and it's something that actually the American Diabetes Association still recommends statins, even though there is that risk associated with it. So I think the take home with diabetes is that it's not a reason not to start somebody on a statin, but it is something maybe to monitor for if somebody starts to develop diabetes post-statin use. The question would be if you withdraw the statin or do you manage the diabetes? And that's going to be a patient-to-patient scenario. I think in a lot of situations, especially if you're looking at secondary prevention, it makes a lot of sense to manage the diabetes and keep the statin on board because of the benefit you're going to get. Or maybe try switching to a different statin, decreasing your statin dose. Those could be some things to try as well. And the big side effect is myalgias. So this is something that can actually pretty commonly happen in patients, unlike the other side effects we talked about. It can be up to 10% or 11% incidence, depending on the study you look at. First case, you always want to rule out your other causes. Your patient just spend their whole weekend getting on a new weightlifting regimen. That could be the reason for their myalgia. So make sure, I know this sounds stupid, but make sure you rule that stuff out, because there are certain people out there that love to associate things with drugs. So any issue they ever have, it's going to be caused by their drugs. And so it's just something to consider, is making sure you're covering your bases. The lab value you can use to check this is creatinine kinase, so you can check and see if that's elevated. Pravastatin and fluvastatin are thought to have the lowest risks, but what I see done more commonly is for people who have myalgia, is what they'll do is they'll just put them on really low doses. So let's say you start somebody at like Crestor 10 or 20 milligrams, and they start to get myalgia. Well, okay, let's try halving that and lowering that. Sometimes you'll see people on like once a week, or they'll take it every other day, and the reason is that the idea there might be some benefit to giving really small doses of statins versus trying a different statin overall. So if you look at Crestor again, go back to this other slide. Let's say, so this is 5 milligrams. Let's say you go like they don't really do this on the chart, so I'm maybe extrapolating a little bit. But even if you did like a 2.5 milligram dose, which would be a really low dose of Crestor, you're still pretty high LDL reduction. So the idea is maybe you can get by the myalgias in doing a strategy that has to do with low doses. So it's something that you see occasionally. Drug interactions, a lot of statins are CYP metabolized. So if something has a drug interaction and it's getting increased blood level concentrations, that can also cause myalgia. And again, myalgia is generally thought to be a dose-related statin complications. That's why targeting lower doses can help. Ultimately, you can get rhabdomyolysis, which is profuse muscle breakdown, which can lead to renal failure. That's super, super rare. More often than not, with statins, you end up just seeing people with kind of a chronic muscle pain, annoyance. It's an intolerance. It's not necessarily a safety concern. However, you can get to the point where it would be. So we do want to watch out for it. We do want to try to adjust it and treat it as needed. All right, managing statin-induced myopathy. So how do you manage this if it actually happens? You're going to hold your statin. You want to wait till the CK to return and symptoms resolve. Check your interactions. Some patients with hypothyroidism are more prone to myopathy, especially statin-induced myopathy, so that's something you can check. You can correct vitamin D deficiency if they're deficient. There's been a hypothesis around coenzyme Q10, which generally has a role in muscle cell energy production. Statins may decrease the amount of coenzyme Q10 your body produces endogenously. I know we think about this as a supplement, but just so you know, your body makes coenzyme Q10. There has been studies looking at supplementing coenzyme Q10. They haven't been shown to be helpful. And in fact, we'll talk about supplements at some point here. But the general rule of thumb with supplements is if your body can synthesize something, it's difficult to replicate that with a over-the-counter supplement. It just doesn't usually have the same effect as what you'd get naturally. So this is no different than that. You can supplement as much coenzyme Q10. If somebody really wants to take CoQ10 to prevent statin muscle pain, fine. I'm not going to argue that with them. I don't think there's any evidence to actually support that. But if somebody really, feels strongly about that, coenzyme Q10 essentially has no safety issues with it. So if somebody wants to take an OTC CoQ supplement, that's fine with me. I just don't think it's actually going to do anything. Okay, so just to round the bases on statins, deciding who needs a statin, use the risk calculator, and guidelines are your guidelines. They aren't law. You don't have to follow them, but you should consider them. They are the best body of evidence we usually have to work with. So I'd highly recommend taking them under consideration. But you might have a patient who's very resistant to statins, and sometimes you get people who, because of their age and maybe some other risk factors they have, they might otherwise be pretty healthy and not have any medications. And you bring up prescribing a statin, and they're like, "Oh, I don't feel like I need that," and that's a common response. So it's on us as providers and healthcare professionals to talk about the risks and benefits of these medications. Some patients will be, so again, the resistance thing. If they want to. I think some strategies that work out is you can promote the healthy lifestyle, and using that maybe as a synergy with a low-dose statin. That might be a way to get somebody on board with a statin therapy. And just reiterating that lifestyle benefits, while effective and can help lower LDL, there's not the proven risk reduction that we have with statins. Choosing a statin, remember atorvastatin, I put simvastatin on here, but I would just kind of ex-nay that one. You could technically use it. Actually, there's a lot of studies out there with simvastatin. It's certainly an effective statin. You're just going to get better effects with atorvastatin and rosuvastatin than you will with simva. Genetic testing. I don't think we're really here yet. Some places might do this, but there is some theory out there that certain patients will metabolize statins differently and get better response from one statin versus another. And so genetic testing might help you refine which statin would work best. Until we get there and that becomes widespread. I say this about every type of genetic testing because I feel like they never really pan out like people think they will. But theoretically, if you could look at metabolism pathways and things like that, you might be able to tailor somebody's statin therapy better. At the same time, though, there's going to have to be a pretty significant enzymatic issue that's going to have you do something outside of rosuvastatin or atorvastatin. So you can't really go wrong with those two as a treatment option. And again, they're both generic, so insurance should have no problem paying for either one. All right. This is just a funny little thing I put in here. This is a really old article that I snapped out here, but it's my reminder to talk about OTC or just statins in general. And I feel like because sometimes in medicine, when you get things that are very, very effective and are being recommended to a lot of people, they generate a lot of buzz. And that can come with negative things too. And there's always somebody out there who hates, something about the positive benefits of a treatment. And so they say, well, we're going to talk about an article on why this really doesn't work or why benefits are overstated or whatnot. But they really aren't. Statins are probably one of the maybe few drugs out there where actually the benefits might be understated. I think in the general population, there's probably a ton of people out there that could use statin therapy and benefit from it that currently aren't on it. So I think that if you review the body of evidence, again, I call them a slam dunk drug. They really are. There's not a lot of drugs I'd say that about, but I think statins do have that
incredibly strong reputation and body of evidence behind them to back it up. I put a little picture in here. I don't know if this is still available in the UK or not, but the UK actually approved Zocor, which is simvastatin, as an over-the-counter option for people to buy. So they're like, well, these are safe enough and effective enough where somebody wants to self-medicate with a statin, go for it. I personally think that's a bad idea, but it's something that somebody wanted to do. I guess they could, and a low-dose simvastatin probably has pretty small risk in the grand scheme of things, but it's still something that I don't think we'll ever see in the United States, but I could be wrong. But just in case, you heard it from me first. Other classes of lipid reduction drugs, I'm not going to talk about a lot of other things because really it's statins or some of the newer agents. And we don't use bile acid sequestrants. We don't use niacin, and niacin derivatives used to be popular. They really aren't used anymore at all. They aren't useful, and you don't really see them. Fibrates we do use, and I'll talk about those for triglyceride management. And everything else. Omega-3 fatty acids is an over-the-counter thing. I'll talk about that very briefly here. But first I want to talk about I'll talk about fibrates and a couple other things here quickly before we finish up. Fibrates are triglyceride lowering if your LDL goals have been achieved. So there's a couple ways, or not, I guess there's a couple ways you can prescribe triglycerides. Remember I said earlier that if you have a high triglyceride level, it can be difficult for the lab to calculate LDL. That's because LDL is not actually measured, it's calculated. So what's measured from your blood is total cholesterol, HDL, and triglycerides. And from that, you do this equation. So you take TC minus HDL minus TG divided by 2.2. That gets you your LDL. If your TGs are super, super high, you end up with a negative number here, and it doesn't make any sense. So there's a certain cutoff there that it just might be difficult to ascertain what somebody's LDL really is. Doesn't mean you can't put them on a statin. It just means you aren't going to have any numbers to go off of. So in that case, getting them on a triglyceride lowering regimen is going to be really important. Not only so you can get a clear picture of their LDL, but also just for general health. Nobody's triglycerides should be that high, and that's a sign of some sort of metabolic issues, probably hand in hand again with diabetes. Usually if people have uncontrolled blood glucose, that's usually associated with high trigs as well. Fibrates are used to lower triglycerides, and so they have their mechanism is PPAR alpha activation, and it results in lipolysis and elimination of your triglyceride-rich particles from the plasma. And so it has this interesting mechanism that's a little bit different than other types of anti-lipid agents out there. It also has some increased synthesis of HDL benefits, which is a nice bump. Minimal mortality data, you do see that risk reduction in CV events for people who have high triglycerides and low HDL. So it's thought that it's helpful, but it doesn't have the body of evidence behind it that statins do, and I don't think fibrates ever will. I don't think anyone's ever going to study fibrates to that extent, but we might see a change. I should never say never, but it just doesn't seem like there's that much information out there about them compared to statins. But what we do have is decent as far as risk reduction. Managing triglycerides, there again 2 fibrates we can choose. Gemfibrozil and fenofibrate are the 2 choices here. You have 2 different products that basically do the same thing, and what happens is they you'd start somebody on this and just check their trigs and see if it lowers. It's pretty straightforward management. They do have some side effects, elevated liver enzymes, not really as much risk of myalgia, but it is rare for both of them, so that can be complicated if you also have a statin on board too, because you don't really know which one might have caused that particular side effect. And whether you pick gemfibrozil or fenofibrate doesn't really matter. I see both of them used occasionally, so I don't have a preference personally. The only thing maybe if you had somebody with renal issues or borderline renal dysfunction, probably going with fenofibrate. Icosapent ethyl I threw in here too. This is kind of a newer formulation of omega-3 fatty acids. So you can, of course, buy fish oil supplements and things like krill oil or whatever other types of oils there are that are omega-3 supplements, which can be helpful for managing lipids. There is some evidence that says that lowering triglycerides, even if they're mildly elevated, can be beneficial, and fish oils or omega-3s in general will do that. So again, icosapent ethyl is an omega-3. And again, you could kind of put any omega-3 in here, but icosapent ethyl tends to have actually some good evidence behind it. It's been more studied in recent history, and there's been some good use of it as far as patients who have history of some sort of issue, cardiovascular, stroke, whatever. They're on statin therapy, and their triglycerides are still kind of inching up to that over 150 mark. People will use icosapent to get those trigs down, and that does seem to have a benefit. So again, these are usually higher risk patients that you'd prescribe this on, and patients who have already optimized or at least maxed, or at least fully attempted, I should say, anti-HDL anti-LDL medications, excuse me. So they're on a statin or something else, and then you're going to add on this on top of it. But I have seen this start to get prescribed more and more, so something to keep in mind. Ezetimibe is a cholesterol absorption inhibitor. It blocks uptake of cholesterol in the small intestine. So the idea is that this works really well synergistically with a statin. So statins prevent synthesis of cholesterol in the liver. This prevents dietary cholesterol from being absorbed. And so it was originally marketed for use in combination with statin. In fact, it was a popular drug that was a combination therapy with simvastatin and ezetimibe, and called Vytorin. And as that drug, or simvastatin, lost its luster, I should say, the other statins kind of took it over, and now Zeti is often prescribed just in addition to them. Interesting body of evidence with ezetimibe. So you have a original trial called the Enhanced trial that basically showed that the outcomes weren't better than simvastatin alone. So people were using this drug and thinking it was the greatest thing ever, and then the data started to come out and people were like, it doesn't really seem like it's any better than just using a statin. So ezetimibe fell off the face of the earth. People weren't really using it that much anymore, until the Improve It trial came out, which actually showed, if we keep studying these people for long term, the enhanced LDL lowering effects of ezetimibe was positively associated with lowered risk of stroke and MI. An additional 15 to 20% LDL lowering, turns out, was substantial over time. So now ezetimibe is considered a good adjunct option to statins. So if you have those patients where you want to target more intense LDL goals, so like getting somebody under 100, getting somebody under 70, or heck, even getting somebody under, seeing as low as you can go. If you got a high risk patient, a lot of times this is a cheap, easy way to add on a therapy that can give you a pretty substantial impact in a patient, assuming they tolerate it. Side effects are pretty rare. You might get some minor GI-related symptoms, and muscle aches actually can occur too, which is great because, again, statins and muscle aches, it kind of confounds the side effects and what's causing what, but that's just the reality you have to live in with lipid management. Again, you have this statin intolerance, high-risk patients. If your LDL is still over 70, give them Zetia and see if you can bump them down a little bit further. And finally, the new kid on the block, the PCSK9 inhibitors. PCSK9 is proprotein convertase subtilisin kexin 9, in case you're really curious about what that stood for. Liver enzyme, it's just a liver enzyme that leads to LDL receptor degradation. So it's got an interesting mechanism of action. And so it should basically break down those LDL receptors to the point where your body just stops making LDL because it's not interacting with anything. It gives this negative feedback loop that decreases LDL production. Monoclonal antibodies. So these are injectable products. So these are large molecule protein type drugs. There's two of them on the market: alirocumab and evolocumab, Repatha and Praluent. And these are sub-Q injections. For Praluent, it's every 2 weeks, and Repatha, it's every month. These have massive LDL reductions. As monotherapy, you can reduce by up to 70%, and adding on to a statin, up to 60%. So let's say you're on a high dose of rosuvastatin already. Maybe you started your cholesterol management at, let's say 200 was your LDL, really high, and you bumped it down to 100 on rosuvastatin, but you want to get below 70. Well, let's add on a PCSK9, and then you can bump them down maybe to 50 or 40 off of that. It's pretty intense as far as the amount of LDL reduction. the areas that these drugs are going to be used that you're going to see are be familial hypercholesterolemia. Familial hypercholesterolemia has historically been statin resistant. It's hard to get somebody's cholesterol controlled with statins. However, these drugs tend to work for those particular patients and therefore reduce their overall risk of having an event. Statin intolerance. So patients who just can't take a statin, they've got myalgia with every single statin available, or even worse, some rhabdomyolysis or something like that. But either way, they can't use a statin. This is going to be a drug option for them. And then again, those high-risk patients with LDL still over 70 who you want to bump down further. As far as insurance goes, that's going to be probably the biggest wild card to whether you'd prescribe one of these or not, because they're super expensive and no one's going to pay out of pocket for them. But I think as they've been around for a couple years now, we're seeing insurances pay for them more. You're just going to have to prove it, prove that they have familial hypercholesterolemia, statin intolerance, or high risk enough and the statins optimized and not working. So there's probably going to be some paperwork associated with getting this paid for, which is just the nature of the beast when it comes to dealing with insurance companies and expensive drugs. And specifically in this case, when you have the statin class that's so effective, the question is, how can you justify an additional benefit with this? And you just have to show them that, they meet some of these criteria here. What about the evidence? The largest meta-analysis showed a decrease in all-cause mortality without increases in adverse effects. This study was regardless of indication or concurrent statin use. So if you used a statin, great. If not, great. You still had evidence of reduced adverse events or reduced cardiovascular events and all-cause mortality, I should say. If the patient was already on a statin, you saw CV event reduction in both of the drug trials as well. Ultimately, pretty good data as far as PCSK9s go. Controversy, I talked about the cost. These are really expensive. And other issues, there's some debate whether in the trial statin intolerance was really a good criteria. Like they didn't really do their due diligence to make sure the person was truly statin intolerant. But that's maybe not the biggest issue to debate on these. There was something about there was some initial controversy about targeting really low LDL levels or how low these LDL levels would get. And there were some of these studies, patients' LDL was like in the 20s, and people were like, that's kind of blazing a new trail in lipid management. We haven't really seen numbers that low ever with statins. It's not really possible to get somebody's LDL that low with a statin unless they started really, really low to begin with, maybe. And in that case, why would you have given them a statin to begin with? So historically, we just weren't comfortable with those types of numbers. And as we have seen those numbers show benefit, I think the more and more we're supporting this low LDL hypothesis that makes a lot of sense. The lower the LDL, the lower the risk. The long-term effects so far seem to be minimal. Long-term, maybe I should use like air quotes with that. These drugs have only been around for a few years. Maybe, how long have these been around? 3 years, 4 years maybe? Not quite. One thing that came out initially was the idea that if you had really low LDL, you could see neurocognitive deficits. And actually, there was some preliminary data that was showing that patients were having some cognitive impairment with these. And the idea, I think, behind that is if you get somebody's LDL really low, maybe that has something to do with how the brain functions correctly with not having enough cholesterol to build new cells, or I don't know, something like that. I'm making stuff up, but you can make stuff up too if you want to. As far as the pathophys on that, I don't think anyone really knew is the question, but there was some kind of a blip in somebody's radar as far as, hey, I think there's some cognitive issues here. And so what happened was they studied that more intensively and didn't really see any differences. There weren't any differences reported in the studies and in the long-term data. So I think that's still being watched, but for now, I don't think anyone's as concerned about that as they were. There are a couple things that happen. People get like these upper respiratory tract infections, nasopharyngitis, injection site reactions, really common with any mAb. Influenza, I don't know exactly why. It seems like, I don't know if it just has some sort of impact on the immune system that we don't know about, like cough, bronchitis, myalgia. I don't know why it has these upper respiratory things, but if somebody wants to dig into that, I'm sure you could find some interesting evidence out there on the internet, but I won't go into that myself. Okay, so just reviewing how we treat lipid management. You've got, again, primary versus secondary prevention. Primary prevention, diet, lifestyle. Take your risk factors into consideration. Usually you're going to look at a moderate statin potency dose. Patient at goal LDL. If the patient's not getting under 100 LDL off of their initial therapy, if it's primary prevention, it's probably not worth increasing it or adding on another drug. And usually if they don't tolerate the statin, we don't add a PCSK9 inhibitor or go with ezetimibe or something like that. Usually just focus on lifestyle modification and call it a day. Secondary therapy is quite different. We're using statin therapy, we're using high dose, high potency for a lot of indications, and we're considering the other agents to get those tighter goals. So consider ezetimibe, consider a PCSK9 inhibitor. And this is just adults without cardiovascular disease. So this would be like a primary prevention type thing based on risk factor and things like that. You can kind of see how they break it down, how UpToDate does anyway. And then low density lipoprotein cholesterol lowering for patients with untreated heterozygous familial hypercholesterolemia. Here's how, again, this is an algorithm from UpToDate, and this is based on familial hypercholesterolemia. However, I think you could apply this to high risk patient too. And it really looks at LDL goal. Are they at goal? Keep them on the statin. Try the statin. If statin doesn't work, add ezetimibe. If that doesn't work, consider PCSK9 inhibitor. And that's sort of the pathway you're going to have to take with higher risk patients. Statin, ezetimibe, and then PCSK9. Those are your three choices and your three classes you're going to try and build on. So if you have a patient, we're talking about patient cases, that's really where I'd be focusing on a lot of. I might give you a primary prevention type case and talk about picking a statin, which one maybe would be a higher potency or something like that. Not that that matters for primary prevention, but again, I think it covers your bases for the future. If you get a patient who's on rosuvastatin and they have a heart attack 10 years later, then they're probably going to be on, you're probably going to want them on rosuvastatin anyway, so maybe it just makes sense to have them on that from the get-go. That's my mentality anyway. And then, with a more intense situation as far as a patient at higher risk, so maybe has a previous MI or has a strong history or a very high CVD risk, maybe they have hypertension and they smoke and their cholesterol is really high, their Framingham or their CV risk calculators, it used to be called the Framingham risk calculator. So anyway, the risk calculator is calculating like 20% or something like that, something really high. That's a patient where we want to be aggressive with, and then we're going to go down this pathway. But that's it for lipids. Hopefully this was a little bit more clarifying from the last lecture during the cardiovascular module. But again, let me know if you have any questions. Thanks.